Okay, thank you, everyone. I think we are good to get started. I want to welcome everyone to What's New in Treatment of Osteoarthritis of the Hip and the Knee. My name is Jamie Jordan, and I am with the Arthritis Foundation. I'm the Associate Director here in New York City and the Long Island area. If you need me, my email is jjordan@arthritis.org. And we're going to get started this evening. I want to introduce you to our guest speaker this evening, Dr. Jason O, MD, who is a board-certified orthopedic surgeon specializing in management of osteoarthritis and other painful conditions of the hip and knee in adults. He is based out of Lenox Hill Hospital in Manhattan. In addition to his clinical practice, Dr. O participates in clinical research with the goal of finding more effective medications and surgical technique to benefit arthritis sufferers. He is also participates in training of residents and fellows at Lenox Hill Hospital. Today, Dr. O will be speaking about what's new in the treatment of osteoarthritis of the hip and the knee. And I'm going to pass it along to Dr. O. Thank you very much for joining us this evening. We're going to hold all questions to the end of the presentation. And then put them in the chat when you do have a question. Thank you. On to you, Dr. O.
Thanks for the introduction, Jamie, and thanks for having me on the session. Thanks for everyone for being here. It's my pleasure to speak to you a bit about what's new in the treatment of osteoarthritis in the hip and the knee. I'm going to do my best to reserve some time at the end for a question and answer. So over the next half hour or so, we're going to quickly cover the basics of osteoarthritis and some of the established treatment strategies. We're going to discuss some of the promising non-surgical and surgical treatment options, and then we'll review some of the history of orthopedic surgical innovation in recent years, go over some of the most popular emerging technologies today. We'll discuss some controversies regarding newer approaches over the years.
Now I can get back in the kitchen.
Wrap up with projections about how future hip and knee arthritis surgery will look. Jamie, I think that we have a few people unmuted in the chat. So to start our discussion regarding the traditional management of osteoarthritis, let's go over some of the basics. So osteoarthritis is a painful and disabling degenerative joint disease, which is the result of accumulated cartilage wear over time. So arthritis exists on a scale and can be either very mild or very severe. The most severe form of arthritis occurs when the cartilage has been completely worn away, and this represents end stage or bone-on-bone arthritis. Cartilage protects the bone and lubricates the joint surfaces. So once it's lost, there can be very severe consequences with regards to pain, stiffness, oftentimes swelling, and loss of function. Unfortunately, cartilage is one of those types of tissues, very similar to nerve tissue, brain tissue, spinal cord, that has almost no capacity to repair itself. And so cartilage damage is generally considered to be permanent and irreversible, making arthritis into a chronic degenerative condition. The goal of the management of arthritis is to reduce pain and maximize function despite the loss of cartilage. We take an algorithmic approach when it comes to the management of osteoarthritis. Many times, purely conservative treatments such as physical therapy and weight loss can relieve osteoarthritis symptoms, and there may be no need to introduce medications, injections, or surgery. Fully conservative treatment options include physical therapy or a dedicated home exercise program, various forms of non-opioid, non-addictive pain medications, topical agents, and nutritional supplements. Weight loss is a key element for those who are overweight, as it can reduce the load on damaged joints and slow down the worsening of the disease over time. Some people may also benefit from devices such as supportive braces or canes if their strength and balance become impaired by the arthritis. One of the commonly used injection treatments includes cortisone shots. In these procedures, we combine a local anesthetic medication with a long-acting steroid and deliver it directly into the arthritic joint. The steroid is a very powerful anti-inflammatory that can greatly reduce the pain and swelling associated with arthritis. However, steroids can have significant side effects if overused, and so I personally limit cortisone shots to no more than 1 every 3 months in any given joint. Another popular option is gel injections. These shots are made out of hyaluronic acid, which is an important molecular building block in human connective tissue. When delivered directly into a damaged joint, gel injections can help to support the damaged cartilage remaining in the joint and block the activity of harmful enzymes. The gel also has beneficial physical properties. Given that it is a gel, it acts as a lubricant and can give direct relief in that way. One of the downsides of the gel injections is that they can be unpredictable, and that as many as a third of patients who receive these injections may receive no relief at all. In addition, they are expensive, and so many types of insurance will not cover the full cost of gel injections. The plans that do will usually cover 2 injections per year. Regardless of the type of injection used, it's important to understand that all types of these shots, whether cortisones or gels, lose their effectiveness over time. And so usually the first one that you receive is going to be the best one. And gradually over time, as you continue using these injections, they become less and less effective, give less pain relief, and for a smaller duration of time. Some part of this is likely due to desensitization of the local tissues to the medication. And some part of this is due to the natural gradual worsening of the arthritic process over time. When non-surgical treatment fails to provide adequate relief of pain or adequate restoration of function, that's when we get involved as joint replacement surgeons. The concept of joint replacement is that the worn out cartilage and some of the underlying bone is carefully removed and then replaced with prosthetic components, which are usually made out of some combination of metal, plastic, and ceramic. Joint replacement surgeries must be performed in a balanced way, meaning that it's important to remove and replace just the right amount of tissue, not too much or too little, and equally important to replace the removed bone and cartilage with appropriately sized and appropriately positioned implants. In this type of surgery, 1 degree or 1 millimeter can make a significant difference as far as ultimate outcomes. Successful joint replacement surgery requires a combination of carpentry, engineering, and knowledge of the anatomy. Conventional or traditional joint replacement surgery does rely very heavily on the surgeon's knowledge of the anatomy, as the way that we plan for bone and cartilage removal is based on our use of specific landmarks in the hip and the knee. Now we're going to get into some of the newer emerging techniques in osteoarthritis treatment outside of the operating room. One of the more commonly used new injection options is platelet-rich plasma, or PRP. PRP is made out of blood, which has been drawn directly from the patient's own body. The blood is processed with a centrifuge, which separates out the blood cells from the plasma, which is the fluid that suspends the blood cells. Once the majority of the blood cells have been removed, the remaining plasma contains a large concentration of platelets, and the mixture is very rich in signaling chemicals called growth factors. Growth factors help to stimulate cellular activity and can help speed up healing and regeneration. PRP has shown some benefit in the healing of other slow-to-heal tissues, such as tendons and ligaments, and there's emerging evidence that shows some potential for PRP to help heal cartilage damage in mild to moderate forms of osteoarthritis. One of the downsides of PRP is that it is still considered by the United States Food and Drug Administration to be an experimental treatment of osteoarthritis, and so PRP treatment is not covered by insurance providers. The out-of-pocket expense for this can be quite high, up to the thousands of dollars. I'm personally involved in clinical research regarding PRP, and I'm enlisting patients with mild to moderate knee osteoarthritis and PRP injection trials that are conducted free of charge, which will hopefully lead to FDA approval in the future. The other hot ticket item when it comes to new biologic treatments for osteoarthritis is stem cells and other cell-based therapy. Stem cells are basic human cells that can transform into other more specialized types of cells. For example, a stem cell placed into a muscle bed may receive signals from neighboring muscle cells to turn itself into a muscle cell, or a stem cell placed into the liver may receive signals to turn into a liver cell. Stem cells can be embryonic, meaning that these are the first few cells produced by the joining of an egg to a sperm, which can then subsequently divide and multiply to turn into a new human being. They may also be what we refer to as mesenteric stem cells, which are stem cells that live in the adult body, for example, most commonly in the bone marrow. Another subset of stem cells may be taken from amniotic fluid and amniotic tissues. This is the bed of tissue in a woman's womb that supports and nourishes unborn babies. Stem cells are very exciting because they present the opportunity for targeted regrowth and regeneration of tissues that otherwise have little to no potential for healing, such as cartilage. Probably the first major application of stem cell research in orthopedics was in the field of spinal cord injury repair, and now we're investigating cell therapies for arthritis. In addition to stem cells, there are other cell-based treatments that seem to show a lot of promise in the treatment of osteoarthritis. We now have the capacity to grow cells of specific types that express genes that may be helpful to reverse the osteoarthritic process. For example, we can cultivate human cartilage-producing cells, or chondrocytes, that create certain growth factors that can promote cartilage healing and regrowth. Both amniotic stem cells and tissue-engineered cartilage cells are also the subject of other clinical trials that I and other doctors at Lenox Hill Hospital have ongoing. Again, the purpose of this research is to eventually find the holy grail of osteoarthritis treatments, which would be a non-surgical cure for the disease, which for all of human history up until now has been considered permanent and incurable. Let's move on now and talk about some advances and innovations when it comes to surgical technologies. Many of these innovations are geared towards reducing the guesswork involved in surgery so that a stable and well-balanced joint can be produced consistently and predictably with as little risk as possible. Computer navigation is a term that captures any sort of enhanced technology that can improve surgical accuracy and precision beyond what can be seen and appreciated with the naked eye. Some navigation platforms rely on live X-rays, such as what appears on this screen. Some others use various other types of optical trackers or gyrometers and accelerometers. Taking things one step further, there now exists an array of robotic systems that can be employed in joint replacement surgery. Like navigated systems, robotic platforms help to plan surgeries by using anatomic data that's collected before and during surgery. In addition to helping to plan the operation, these robotic systems also assist in the execution of surgical steps, such as removing bone and installing certain components. Many of the robotic systems currently in use in the United States today are capable of performing surgical steps to within 1 millimeter or 1 degree of accuracy or less. And so these devices can help to reduce the likelihood of human error and make these operations more predictable and more consistent. Patient-specific instrumentation, or PSI, refers to custom-made equipment to be used on a case-by-case basis. These can include bone preparation tools, such as the white plastic items that you see here, as well as custom-made implants, such as the metal components that you see here. These devices are fabricated based on pre-operative imaging studies, such as CT scans or MRI scans. Using systems like these can improve operating room efficiency by cutting out some of the steps in surgery and can oftentimes be helpful in patients with unusual or difficult anatomy, such as someone with a history of a prior knee bone fracture or with obesity. From here, I'm going to focus a bit more closely on robotic surgery, which is one of my main interests as an orthopedic joint surgeon. Taking a step back, let's look at some of the history of robotic surgery. The first robot involved in any sort of surgery was this device, the Puma. In 1988, this large and fairly clunky looking robotic arm was used successfully to perform a brain biopsy. 3 years later, in 1991, the same system was used for a urologic procedure, a prostate biopsy. The Puma served as a proof of concept on the notion of robotics being applicable in the field of medicine and surgery. So afterwards, the idea caught on and other robots began to enter into the surgical landscape. Robotic platforms such as the Zeus and the Da Vinci robots were used for procedures in various surgical subspecialties such as general surgery, urology, gynecology, and cardiothoracic surgery, with applications in minimally invasive gallbladder and uterus removal surgeries, lung resections, heart valve replacements, and cardiac bypass surgeries. As these technologies continued to be adopted in a widespread fashion, we saw that they allowed for successful surgery with the use of smaller incisions, better precision, improved visualization for the surgeon, quicker recovery times for the patient, and shorter lengths of stay in the hospital as compared to traditional surgical techniques. Here's a picture of the Da Vinci robot. As you can see, this particular system makes use of a variety of robotic arms, which are capable of making very subtle manipulations at the ends of very narrow arm extensions. Cameras can also be suspended from the robotic arms, which can afford an excellent view of an otherwise very, very small surgical field. The Da Vinci also gained some popularity and notoriety in pop culture via social media when some surgeons successfully used the device to perform mock surgery on the skin of a grape. When it comes to orthopedic surgery, the first platform used for a live hip replacement was this device, the RoboDoc. Really only seeing use in some European countries, this system required a preoperative CT scan to help prepare the thigh bone to receive an implant in hip replacement surgery. As you can see, the device itself was extremely large, required a fairly invasive surgical procedure, and so for various logistical and technical reasons, never really gained much traction in the US or in the orthopedic world at large. But subsequent versions of orthopedic robots improved on the RoboDoc with respect to less bulkiness, greater finesse, and much greater ease of use. The Mako surgical platform was introduced in 2006 and was later acquired by healthcare giant Stryker. The Mako has applications for both hip and knee replacements, and after a lengthy trial period, the FDA granted full approval for all its applications in 2015. Even before full FDA approval, though, the popularity of the Mako was growing by leaps and bounds, and so Stryker's industry competitors all began developing their own rival robot platforms. In 2014, the Navio system from competitor Smith & Nephew gained full FDA approval for clinical use. In 2019, the ROSA from Zimmer Biomet followed suit, as did the VELYS system from DePuy Synthes in 2021. Let's review some of the commonly used advanced technologies in joint replacement surgery today. This device is called the IntelliJoint, which uses these Hollywood-style optical motion trackers and high-definition camera to gauge where each bone is in space. This is a type of a navigated system that helps the surgeon to perform bone resections and to judge joint alignment during the reconstruction process. This system is the RadLink, which was shown a few slides earlier. This system uses live surgical X-rays or portable X-rays known as fluoroscopy during surgery, mostly for hip replacements. This is another navigated system that can assess X-rays and produce accurate numbers in live time that would otherwise have to be eyeballed and guessed essentially by the surgeon. The OrthoLine is a more portable navigated system that relies on the use of accelerometers. The computer is completely contained in this small unit, which is pinned to each bone during surgery and taken through a variety of maneuvers to help the surgeon establish the long axis of each limb and help to plan the bone cuts based on preoperative planning. The Mako robot, again, is a giant in orthopedic joint surgery technology, and it involves a haptically guided, meaning that the robot confines the area of surgical intervention to a specific area which is predetermined to be safe, though the surgeon controls every aspect of the actual steps of the operation. So this is not what we call an autonomous robot where the robot is operating on its own. This is a surgeon-guided active robot where the surgeon is in charge and responsible for every step that's taken during the procedure. The Mako robot is useful for both hip and knee replacements, but it does require a preoperative CT scan, essentially building a bone map, and the robot and the surgeon follow the map during the course of surgery and follow the steps. The ROSA robot by comparison is another robotic arm system, but does not involve any haptic guidance. So this is purely controlled by the surgeon. One of the advances or the advantages of the ROSA robot over the Mako robot is that it does not necessarily require an expensive CT scan. The ROSA platform can be used with either a preoperative MRI, preoperative X-rays, and can actually be used with no imaging at all, just intraoperative feedback assessed by the surgeon during the time of the operation. The Navio robot, unlike being a large robotic arm, is actually a handheld system. It's also haptically guided, meaning it doesn't allow the surgeon to exit certain bounds that are considered to be safe. And as with the ROSA robot, no CT scan is required in order to use the Navio live. So some of the controversies regarding innovative technologies. Anytime that a new technology is introduced, there's always very active debate in the orthopedic community about whether it represents an advance, neutral, or actually a worsening of the existing technology. And so this is a debate that always has to be continued as we continue to roll out new advances in surgery. So the upsides of innovative technologies is that, and this has been pretty conclusively shown in the studies that we've done, is that use of navigation, robotics, and techniques like this do improve accuracy and precision when it comes to bone preparation and component implantation. These devices are more accurate and more precise than humans alone, even experienced surgeons. And there are certain clinical outcomes that are enhanced compared to conventional joint replacements, such as speedier recovery, improved pain and function over time, fewer perioperative complications, and questionably lower costs when all things are considered. However, some of the downsides from the detractors of these types of advanced technologies. So some studies have shown that computer navigation and robotics can improve certain outcomes, whereas other studies have disputed those same points. Another concern is that relying too heavily on these advanced technologies may leave a surgeon unprepared if the technology itself, whether it be the robot or the navigation system, malfunctions. And so a surgeon who's not trained appropriately on conventional instrumentation may be in a bind if something breaks in the middle of surgery. Finally, many of these devices and technologies are relatively new, within 1 to 2 decades of introduction, and they don't have long-term outcomes data for 25 years, 30 years, 40 years down the line. We don't know ultimately what the long-term effect of using these types of equipment and advances would be. Cost is always an issue in today's world and with today's insurance landscape. And so these devices are costly. A single Mako robot is approximately $800,000 to purchase up front, and does require disposables that are rated at approximately $1,200 per case, and this must be paid by someone. In addition, the CT scan that has to be routinely done for any Mako case can range up to about $2,000. Again, does require a payer to foot the bill. And so in order to offset these upfront costs, then we have to be able to realize significant cost savings on the back end, which is to say reducing the number of complications, reducing hospital readmissions, reoperations. And that's the way that we have to prove that these technologies are really worth adapting from a dollars and cents perspective. I'm going to go over some of the recent trends and the use of these innovative surgical technologies. Regarding use of navigation and robotics and total knee replacement, one study looked at the trends in the 8 years from 2010 to 2018 and found that the total usage of some sort of advanced technology was about just under 8% in a large database. And the rate of usage was climbing exponentially, with robotics climbing 22-fold from 2018 as compared to 2010. Based on the modeling that was done by these authors in 2030, they projected that over 6% of knee replacements will be somewhat computer assisted, and almost 50% of knee replacements will be robotic or robotic assisted. When it comes to total hip replacements, the similar paper looked at trends from 2005 to 2018, and they found that the rate of computer navigation improved from 0.1% to 1.9%, and robotic assisted hip replacements increased from less than 0.1% to 2.1%. And their projections that were by 2030, just under 6% of all hip replacements would be computer assisted, and over 60% of hip replacements would be robotic. So again, following that exponential trend over time. So we're ending at 6:30. We have a good amount of time for questions. I think hopefully we have some questions potentially in the chat. And this is the QR code and Ortho Fast Track contact information for anyone who's interested in scheduling an evaluation or learning more. So I guess, Jamie, we can open it up.
Yes. So if anyone has a question, please write it in the chat, or you can raise your hand and I'll unmute you. Laura just wants to let you know this was super info and thank you.
Okay, thanks.
Are there any questions? I don't see any coming in, Dr. O.
It's all right.
Yeah, if anyone has any other questions they think that they would like afterwards or think of after this presentation, you can always reach out to me at jjordan@arthritis.org and I can get them over to Dr. O. We can get you the answers pretty quickly. But I'm going to do last call for any other questions. I'm going to say that was a great presentation and very thorough and very descriptive. And thank you, Dr. O, because no one has any questions at the moment. But thank you very much for everyone joining us. Again, if you have any questions, you can just shoot me an email and I'll get them over to Dr. O. And Alana wants to say thank you so much. Wonderful talk. And I can't agree more. It was a great presentation. Thank you so much for all the information and have a great night.
Thanks, Jamie. Thanks, everyone, for participating.